Hello everyone, I am Ohno from Gunma University, Japan. I would like to talk about Japanese experience in the treatment of cervical cancer. This is a virtual kabuki painting on my face. Nice to meet you. We have several guidelines on cervical cancer, general rules for clinical and pathological management, the treatment guidelines of uterine cervical cancers established in cooperation with the Japanese Society of Gynecologic Oncology. Treatment planning of radiotherapy and brachytherapy were published by the Japanese Society for Radiation Oncology. In this figure, clinical stage, histology, and the corresponding treatment recommendations are shown. Squamous cell carcinoma in stage 1B1 and 2A1 can be treated with either with radical hysterectomy or radiotherapy alone. For bulky tumor in stage 1B, 2A, and 2B, surgery remains a choice of treatment in Japan. For stage 3 and 4A, concurrent chemoradiotherapy is a standard of care. Several clinical characteristics are well known as a negative prognostic factors. First is the tumor size. This table shows clinical outcomes of Japanese prospective study using CCRT for locally advanced cervical cancer. With the increasing of tumor size, the 2-year pelvic control rate decreased. In this study, point 0.8 dose in brachytherapy was constant irrespective of tumor size, which caused insufficient control for large tumors. I will mention about the impact of image-guided brachytherapy on tumor control improvement later. The second is adenocarcinoma histology. This figure shows a comparison of overall survivals between squamous cell carcinoma and adenocarcinoma in stage 1, 2, and 3. Compared with squamous cell carcinoma, adenocarcinoma histology demonstrated inferior survival, especially in stage 2 and 3. Third is lymph node metastasis. This figure shows comparison of overall survival and lymph node control between pelvic lymph node positive and negative patients. Patients with pelvic lymph node metastasis shows significantly lower survival and nodal control. In Japan, we have a long-term history in high-dose rate brachytherapy for cervical cancer since 1960s. Brachytherapy is now shifting from point A based 2D planning to CT based 3D planning, which results in individualized dose prescription. 3D CRT with box technique is commonly used for whole pelvic radiation. Central shielding technique is performed based on the disease progression. Weekly cisplatin at the dose of 40 milligrams per square is commonly uh, combined for locally advanced disease. This slide shows standard radiotherapy schedule in Japan. For early disease, a central shielding and brachytherapy is started after 20 gray of whole pelvic radiation. In principle, pelvic dose is 50 gray in 25 fractions. and brachytherapy dose is 24 gray in 4 fractions. For locally advanced disease, central shielding is began after 30 or 40 gray. A 6 to 10 gray of boost will be given to the positive lymph node. In this schedule, what do you think about a composite dose from external beam radiotherapy and brachytherapy? On the left side, you can see the composite dose distribution from whole pelvic radiotherapy and brachytherapy. On the right side, you can see the composite dose distribution from whole pelvic radiation with central shielding and brachytherapy. The bladder and rectal dose are spared by central shielding, which looks like butterfly shape. Total dose is expressed by 50, 60, and 70 gray EQD2 for both planning. What about the dose in the target volume? Please look at the coronal dose profile on the white line. So, okay, these lines indicate external beam dose. The dose of central area decreased because of the shielding. On the other hand, uh, this line shows brachytherapy dose, which steeply increased in the target lesion. As a result, total dose is over 100 gray of the central area, which can compensate the decreasing dose by central shielding. So brachytherapy remains essential. This is a target volume modification by external beam radiotherapy at Guma University. For patients with para-aortic lymph node metastasis, we adopt extended field radiotherapy concurrently with weekly cisplatin at the dose of 30 milligrams per square. For low-risk patients with stage 1B to A, tumor size less than 4 cm, and no lymph node metastasis and squamous cell carcinoma, common iliac node lesion is excluded from the target volume. Prophylactic radiation for para-aortic lymph node lesion is a controversial issue. One strategy is careful observation, and if isolated tumor recurrence is observed, radiotherapy or CCRT can be given. Another strategy is to provide prophylactic radiotherapy to the para-aortic region. This figure shows treatment protocol of FNCA cervix 4 trial. Para-aortic lymph node irradiation was started after 30 to 40 gray. This study was performed among 11 Asian countries, including Bangladesh. A total of 95 patients were enrolled, and favorable local control, overall survival, and progression-free survival with minimal toxicities were observed. So let's move on to the brachytherapy. The implementation of 3D image guidance, treatment planning, and DBH parameter evaluation represent a major advancement in gynecologic brachytherapy. In point A based brachytherapy, there is a concern of underdose for large tumor and overdose for bowels and bladder in the small uterus. In contrast, target volume-based dose prescription can realize individualized treatment, especially bulky tumor control will be improved without increasing of severe toxicity. MRI is a golden standard of treatment planning in image-guided brachytherapy. However, CT is most commonly used imaging modality, including Japan and probably in most of Asian countries. In the multi-steps of development in IGBT, many of Japanese centers use CT in every session, and diagnostic MRI just before first session of brachytherapy is also used. Gunma University has an in-room CT-guided brachytherapy system. This system is clinically advantageous in reducing the number of applicator displacement, the burden for patient and medical staff, and the time delay for radiation. In case with bulky and asymmetric target volume, we use a combination of intracavitary and interstitial brachytherapy. In this technique, insertion of interstitial needle is aimed to the area which will be insufficient coverage by intracavitary brachytherapy alone. Ultrasound guidance is mandatory. This is a representative case showing extensive tumor invasion to the left pelvic wall before and at 30 gray. Interstitial needle was inserted under the ultrasound guidance at 4 o'clock, uh, along with the inside of the left ovoid. This slide shows the difference of dose distribution between intracavitary brachytherapy alone and hybrid intracavitary and interstitial brachytherapy. 6 gray is our aiming dose, and there is an insufficient target coverage with intracavitary brachytherapy alone. However, hybrid brachytherapy significantly improved the target dose coverage. After treatment, the patient didn't develop any recurrence and late complications. This slide shows other patients treated with a hybrid brachytherapy and interstitial brachytherapy. At Gunma University, the 5-year local control rate were 94% for stage 1, 97% for stage 2, and 90% for stage 3 to 4A. The 5-year local control rate was over 90, irrespective of tumor size. For late toxicity, one patient with liver cirrhosis developed grade 3 urinary toxicity that required blood transfusion and hyperbaric oxygen therapy. The 5-year overall survival rate were 89% for stage 1, 97% for stage 2, and 72% for stage 3 to 4A. Recently, Clinical outcomes of IGBT has been published from many institutions including Japan. Sky blue area is reports from Japan. Irrespective of the imaging modality such as CT or MRI, the local control is favorable without increasing of the late severe toxicity. The difference of target contouring can cause dose uncertainty, and such uncertainty should be minimized. In Japan, gynecologic radiation oncology experts developed the target definition in CT-based brachytherapy. This is a case of stage 2B at diagnosis. The tumor responded well at the time of brachytherapy. Pink area shows GTB at diagnosis and just before first session of brachytherapy. And red area shows high-risk CTB on CT image with applicator. Sometimes the bowel may have a similar density and be immediately adjacent to the cervix and parameteria. The overestimation on CT can be minimized by tracing the diameter D1, D2 in high-risk CTB contouring on MRI just before brachytherapy. In addition, oral intake of gastrographin is helpful to distinguish the border of bowel lumen. The agent is diluted with water and is administered orally 2 to 4 hours before brachytherapy. This is a comparison of median time for each brachytherapy process between 2D and 3D brachytherapy. The nationwide survey demonstrated significantly longer time for image acquisition and treatment planning. So education and training are very important. We developed a training phantom, which is commercially available now. This is a DVD including knack and pitfall in brachytherapy. In addition, we have hosted some international and domestic training courses and fellowship programs. This is Professor Petta. I would like to introduce two ongoing prospective clinical studies. First is a multi-center prospective study on image-guided brachytherapy for locally advanced cervical cancer. 8 Japanese centers participated, and the clinical outcomes will be analyzed this year. Second is multi-center prospective observational study on image-guided brachytherapy for locally advanced cervical cancer. This is FNCA trial, and representative center from 11 Asian countries participated in this trial. In summary, the regimen of 3D CRT and image-guided brachytherapy with or without weekly cisplatin is widely used in Japan. Excellent primary tumor control has been obtained with 3D IGBT, in which physical examination, MRI at diagnosis, and just before first session of brachytherapy, ultrasound-guided applicator insertion, and CT-based treatment planning are integrated. It is important to promote the education, training, and conducting clinical studies in the management of cervical cancer in Asia. Thank you very much.